Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
This is an example of something that has distinguished Lewis Ivy. You can you scroll on down so we can see the fact that he's one of the heroes, and then they honored the battleship honored American heroes on the 23rd of May this year. And scroll on down. And this is a list of the honorees, and you see Lewis Ivy there. Captain. Is that the right designation, Lou?
Yeah, that's the right. The it's equivalent to colonel in the Army, but captain in the Navy.
I see. Okay. Well,
Like
scroll
an
on down.
airplane pilot, captain.
Okay. Scroll on down because they have a great write-up on Lou.
This is all I got.
Oh, that was a. Oh, really? That's unfortunate because there's a write-up on it. I thought you got that too. That talks about his distinguished career as a cardiac surgeon and as a naval officer, on how that he actually was one of the people who went along with President Carter as his cardiac surgeon. And Lou, maybe you can tell us a little bit about some of that that's in the article that we didn't show.
Yeah, when I went in I was in college and it was during the Korean War. And of course, they were drafting everybody right and left, but students who were in college, if you maintained a B average, they said they let you graduate. But apparently that didn't apply to Black folks. A lot of my classmates got drafted, so I was forced into selecting an ROTC program. So I joined the Navy ROTC, and at my school, there were only 52 colleges in the country that offered this program because it was analogous to the Naval Academy. We had to take all the same courses in addition to whatever else we were majoring in. So I went to Penn State and I got in as the first Black Naval ROTC student and graduate. And they didn't invite me to join the Honor Society, so I asked them why not, and they couldn't give an answer, so they had to admit me. And when I graduated, I was the vice president of the program. Then when I left the school, I went right into the Navy, and I was stationed aboard the battleship New Jersey, and I was the first Black officer. This was in 1954. They didn't have too many Blacks in an officer position, and I was the first on the battleship New Jersey. And the battleship New Jersey is a very large ship. It's about 3 football fields in length and 1 football field in width.
Wow.
And the height is up to about 4 stories. So
wow.
It was the largest ship. There were 4 battleships in the American fleet, and the Arizona got destroyed in Pearl Harbor. And that left the Iowa, the Missouri, and the New Jersey, which were all commissioned in a year later after the war. That's in 1942. When I left the New Jersey after standard period of service there, it was 2.5 years. They sent me to Germany because I spoke German. And in order to have that position at the Rhine River Patrol, the Rhine was divided just after the war into 3 sections, the French, American, and the British, for control of the flow of traffic on the Rhine and to collect intelligence. So I was the officer in charge of the American and the German units on that patrol. And during my time there, they would send us out on intelligence gathering missions. And one time they sent us up to Hanover, Germany, which is a High German, Hochdeutsch. They only speak very literate book German. So colloquials don't work too well. So anyhow, they would never send us as one person. We always go in pairs. And all of the officers in the Navy that were stationed there had to speak at least one language other than English, that is European. So I was sent with a partner who spoke Italian. His name was Julian Perino. And we went to Hanover and we checked into this hotel. It was actually a beer stube, a beer hall, and they had rooms upstairs. So we were supposed to mix with the natives. We went dressed as civilian and got to the desk, and I'm asking about the city of Hanover and where we could go to get this, that, and whatever. And my partner spoke no German. So we're standing there at the desk, and I'm doing all the talking. And the proprietor was looking at me, and then he looked at my partner. And of course, Julian's lips were not moving and mine were. So the guy he looked confused because I was doing the talking. So he would ask questions, and he looked Julian in the eye and expected an answer. And then this voice from the other side of the room was me. He looked over there. I'm sure he thought that Julian was a ventriloquist and I was just because we as Blacks were not supposed to speak other than English and barely English. So that was an experience. After I left Germany, I came back to the States, went to med school, finished in 1963, and then went on to do my residency in surgery and then cardiovascular surgery at Cornell in New York City in Memorial Sloan Kettering. And then I came back to Howard. And that's when I, my team completed the first aortocoronary bypass, which is for heart attack patients. We take a vein out of the leg and connect it to the aorta and then to the heart to provide blood. And so this was the first one in the city. After that, I was asked to accompany President Carter to Japan on his first official visit as a cardiac surgeon on his team, because at that time, all American presidents, if they leave the country, they had to carry their own medical staff because they didn't trust other foreign countries to provide the best of care for their president. So when I finished that, I because Dr. Johnson, who was the cardiologist, chief of medicine at Howard when I came back, he died, and Dr. Charlie Curry had to take his place. Charlie was the only one in medicine trained at Howard to do invasive cardiology, in other words, to do x-rays of the arteries of the heart. And so once Charlie could no longer do that, the program dwindled and died. And I started the first surgical intensive care unit at Howard, and it's probably still going. But I designed it and staffed it and equipped it. And after that, when I left Howard, after Dr. Johnson's death, I was chief of surgery with Baltimore at Providence Hospital. And I was in charge of the residents from Harry. And long story short, I retired from the Navy in '91 after being recalled to Desert Storm, Desert Shield. And I was at that time sent to Portsmouth Naval Hospital and also Bethesda Naval Hospital to staff and train the residents. And that's it in a nutshell, pretty much.
Well, tell us about when they named the battleship in your honor.
The ship was not named in my honor. They honored me for being the first Black officer. And that was done, I guess in about 10, 12 years prior to that. They had held a special ceremony as the first Black officer on the ship. So I'm a part of the history of the ship, which is a distinguished ship, the most distinguished battleship in the U.S. Navy. And I served on it during the Korean War. So they didn't name the ship, but they did put my picture on a flag there at the base, because the ship is down in Camden, New Jersey, and it's a museum for the Navy. And they have the entrance where you come in, their poles are all around, like light poles. And with my picture is on one of them, a big poster of the picture that was on that brochure that I sent you, Clive.
Mm-hmm. Right. Well, it's quite a distinguished career that you've had, and we appreciate the fact that you shared that wonderful history with us. I was with Lou when he was working with performing the cardiac surgery, and also when he started the ICU. It's interesting, though, that very few people are aware of the fact that he was the one who started the ICU from the get-go. And if you asked people at Howard, they would probably not even be aware of the fact that Lou was the one who began that. But we certainly appreciate all that you've done to make us proud that you've joined us once again. Any other questions or comments for Lou?
I just want to comment that that's such a rich history. But when you mentioned Charlie Curry, that was my mother's heart doctor.
Mm-hmm.
There at Howard.
We worked together. We went down to Tuskegee, had the Tuskegee plan, how the Blacks were mistreated in terms of experimentation. Mm-hmm. Well, he and I went down to Tuskegee together, but we were good friends. We worked together.
He's still around. I don't know. I don't know who's older, you or he, but I know he's still around. He's retired as well.
Yeah. Mm-hmm. He's got a daughter who's medicine, right?
I know he has a sister.
Oh yeah, sister. That's what it was.
Sister who's the first Black gastroenterologist.
Sadie.
Female. First, Sadie Curry, first Black female gastroenterologist in the United States. Mm. She's retired.
Dr. Callender and I worked together when he was doing the transplantation. He started the transplantation at Howard, and I got back from my training just a year before he finished, right, Clive?
Yeah, that's right. That's correct. Yeah.
So we all three worked together with Teddy Warner.
Right, because I came back in 1973. Mm-hmm. Yeah, and you guys were already doing your stuff.
Yeah.
Okay, well, thank you very much. We're proud to be part of your history. Yeah. So
it's a pleasure to share it with you.
Could I ask him again the names of the 4 battleships? I remember, of course, the Arizona, and you said New Jersey. What were the names?
The Iowa.
Iowa.
And the
Missouri, did you say?
The
Missouri.
I don't know why it slipped my mind, but getting old, stuff slips away.
Thanks.
But it was the ship that the peace treaty was signed with Japan. So that was the battleship. Holy cow! I'll think of it before we finish the meeting, and I'll tell you.
All right.
Okay. All right.
Very impressive. I'm proud to know you.
Yeah.
Well, back in those days, it was kind of tough for Black folks. and especially in the military. And going on that ship and there's segregation and problems that you encounter. But that's part of life. We didn't object to it. We had to live with it, and there's no point in complaining. Just go ahead and do what you have to do.
Well, it's amazing what they did with you in your college.
Yeah.
You had to fight for everything there.
Yeah. I mean, a classmate had told me, he said, yeah, we're having the introduction to the Honor Society tomorrow night. Are you going? And I said, what society? And I said, what do you have to have? What kind of grades? And he told me, and I had that. So I went to the dean and said, why am I not invited? They couldn't figure out an answer. So it's like, oh, I'm sorry, we just overlooked. So I said, that was that. So I got in and began to lead it.
Well, racism is interesting.
Yeah. But you can't sleepwalk. You got to be.
If you don't fight back, boy, they'll just take advantage of you.
Oh, really?
Yeah. Well, anyway, congratulations on fighting back in a very special way.
Thank you.
And forcing them to acknowledge you.
Well, since that time, I've been awarded distinguished alumnus from the school.
Yeah, I noticed that. That's what's so interesting. They then named you later as
Yeah.
yeah, after they treated you that way. Yeah. Oh, well. It's good to be gracious.
Yeah, right.
Okay, well, this is National Minority Donor Awareness Month, and so I wanted to just share that with the group and share with you some of the way in which this actually developed. It's interesting how things develop, and this is a story of how this took place. I have nothing to disclose, and all we're going to talk about is how National Minority Donor Awareness Day, week, and month developed. And so the next slide points out that the number one problem in transplantation yesterday, today, and likely tomorrow is the shortage of donors. Because of this shortage, 17 people die every single day because of this donor shortage. But it all began for us actually in 1978 because they brought it to my attention that minorities represent more than 50% of those waiting, but only 15% of the donor population. And at that time, they thought Blacks were not likely to donate. And the next slide shows that it actually began in 78 when they came to me to request my participation to help solve the donor shortage. But as is often the case for minorities, they had no funds to support this effort. And so they shared the data with me, and I shared the data with Dr. James Baton, who's an eminent psychologist. And we reviewed the data and decided this was so important because it affected us. And with that in mind, the next slide points out that we obtained $500 from Howard University and used that money to survey 40 Washington, D.C. residents. And we identified, importantly, two important aspects. One, the 5 reasons Blacks were reluctant to donate, and secondly, ways to overcome their reluctance to donate. And the 5 reasons are shown in the next slide. The obstacles were first. Next slide, the next slide will show you that transplant awareness was the first issue. The fact is that Blacks were not aware that we were more needy than any other ethnic group, but yet we were rarely donors. And so this was important for us to make sure that people became aware of this, number one. Now, number two was religious myths and misperceptions, concerned that in that great getting up morning, you go to the pearly gates, if you only have one kidney, you only get one wing. If you don't have your eyes, you can't see great grandmama in the hereafter, forgetting that it's in giving that you receive, it's in pardoning that you pardon, it's in dying that you're born to eternal life. And Christ came and died and gave his life. And so it is the right thing to do to leave organs and tissues in life and after death. The third reason had to do with the fear that if I go to the doctor after an accident, they're more likely to declare me dead than to keep me alive. This is not true, and so we had to overcome this third obstacle. The fourth obstacle, next slide, was the basic distrust. Lou mentioned the Tuskegee incident, and that was one of the times in which we used as guinea pigs. There are many circumstances in which minorities have been used as guinea pigs. This is just one of the many. And so we had to overcome the distrust. And then finally, racism. The fear that if I give my organs, they're only going to go to a white person, and that we're not going to be the recipients. And so these were the 5 reasons that they identified. But one thing that happened is after we did this study, we identified that when we started the study, only 2 of 40 people were willing to sign donor cards. At the end of the presentation, all 40 signed donor cards. This said to us that we had in hand a mechanism to use education, community education, to overcome all of the 5 obstacles. And with this done, we started the DC Organ Donor Program, got money from the Dow Chemical Company to start the Dow Take Initiative Program, went across the United States to 25 cities. Because of the success of this effort, we recognize if it works in the Black community, and the Black community is a group that is thought not to be willing to donate, it would work in all communities. And so we conceptualized MOTEP. And thanks to these 3 people, Congressman Louis Stokes, Secretary of Health Louis Sullivan, and John Ruffin, we were awarded some $16 million over the next 15 years to develop MOTEP sites across the United States. Next slide shows the states that actually the ethnic groups that were involved: Latino Hispanics, Asian Pacific Islanders, African Americans, Native Americans, and Alaskan Natives. Based upon the successful methodology that we used with the Black population, we applied these to the other target audiences. The next slide points out that our mission statement is to reduce the number and rate of ethnic minority Americans needing organ and tissue transplants. This then, of course, was an important mission, and the next slide shows that we then, after we had done much of our work, we decided that there ought to be a National Minority Donor Awareness Day. At that time in 1996, there was none. And we got a proclamation signed by the United States Senate on July 10th of 1996, with co-chairs Bill Frist and Joe Motley, the District of Columbia, Mary Anthony Williams, and President Clinton as well, commented and promoted National Minority Donor Awareness Day. And the goal was to increase the number of minorities who donate, who receive transplants, and adopt healthy lifestyles. And the real problem is that while we comprise 25% of the population, because of our predilection to diabetes, hypertension, heart disease, and obesity, we make up more than 60% of those who are waiting for transplants. And at that time, 22 people were dying daily. Now we've done better, and so it's down to 17 people dying daily because of the shortage of donors. So we launched this in August of 1996. Because of its success, in actually 2012, the AMAT, which is the Association of Multicultural Affairs and Transplantation, and the organ procurement organizations, they requested to change it to a week because it was important to do that, to increase the number of minorities' participation. Then in 2020, they recognized that this was so important that it needed to be changed to a month. And so as of August 1st of 2020, it became National Minority Donor Awareness Month. And I think these all helped to accomplish a major accomplishment in 2010. Blacks were ranked above whites and other ethnic minority populations as the #1 ethnic group of organ donors promoting within the United States. Kind of a modern miracle to see something where we were at the bottom of the list and then we jumped to the top of the list thanks to efforts like this. So this is what National MOTAP has been all about, and this is one of the things that has helped this happen. Next, we want to show you 3 of the videos we created and launched in National Minority Donor Awareness Month. There are 3 videos that identify the nature of the problem and the solution. We are part of 4 historically Black colleges that are working with regional organ procurement agencies to increase the number of people of color at the top of organ procurement agencies, and to increase the number of people of color in the field of transplantation. And so maybe you can start showing the first video.
Okay, hang on a minute.
Okay.
I have to back out.
What we've done, okay, while he's doing that, is that we recognize that one of the areas that is not appreciated is the fact that in middle schools and elementary schools, this is not done. These are videos we're going to send to. Can you get the sound at all?
When we did our test yesterday, it worked. All the way up.
Established to decrease the rate and number of ethnic minority Americans who require organ and tissue transplants by means of illness prevention and education. Today, MOTAP would like to highlight how simple it is to give someone a second chance at life.
Hey everyone, my name is Katora and I'm here to talk about organ and tissue donation. While organ donation is a sensitive topic, it's incredibly important to so many people around the world, including me. I received a new liver because mine wasn't working well. And because of my liver donor, I'm alive and happy and healthy today. Organ and tissue donors are heroes, people who give the gift of life while they're alive or at the time of their passing to help someone like me. At only 2 weeks old, I began showing signs of liver failure because of a disease. And instantly, my parents became deeply concerned with the outlook of my future health. Unfortunately, Black, Indigenous, and other people of color are at higher risk for organ failure. These disparities and lack of access to credible information cause unequal harm to our communities. In fact, not having general information on donation is one of the reasons why my family had no idea what the future would hold for me when my symptoms started. But they did everything in their power to improve my health and left the rest to medical professionals and the universe. At 13 months old, I had surgery that would change my life. I received a much needed liver transplant. Because of that, I've been able to live a full life with my family and loved ones, and I had a normal childhood. I've traveled the world and I'm pursuing all my dreams. I have laughed, loved, and lived, and I'm beyond grateful that I received that donation from a living donor, my own mother. She donated a portion of her liver so that I could have the life that I have. Sadly, this is not everyone's story. Some people wait years for the right donor and the right organ, but more people who register to be donors means more people have the chance of getting a life-saving transplant. And there are many more organs or tissues that can be donated than people realize. Together, we have a lot to give to those in need. By registering to be an organ donor, you have the opportunity to save lives of people like me, offering them a second chance at life and leaving a miraculous legacy is something that we're all capable of. So learn more about it today.
It's going to show the second video.
Every day, a superhero chooses to be kind by simply saying yes. And if you can give me a second, I can tell you how these three simple letters, Y-E-S, have granted me a second chance at this fantastic thing called life. My name is Olivia Jones, but my friends and family call me Liv for short. I am a student at Spelman College in Atlanta, Georgia. Going to Spelman has been a lifelong dream, especially since I discovered my mother was a student there years ago. Today, I want to tell you the story of how I got into Spelman. Sure, it was a lot of hard work, making sure I did my homework and got good grades. But my journey actually started when I was a baby. One day during an examination, doctors told my parents something was wrong with my heart. After several tests, they discovered my heart was too big for my body. At the time, I was really sick, and the only way I would live a healthy life was if I received a heart transplant from another child the same size as me. Ashley's dad was so sad that he lost his daughter, but he made the brave decision for Ashley to be an organ donor to help kids like me whose organs weren't working well. And that is how I got a new heart, Ashley's heart. Thanks to Ashley and her dad, I am alive today, and the best way I can honor Ashley is to live my life with purpose and help others. That's because many diseases impact our community. This is why it is so important we take care of our bodies and make healthy choices. I hope that other kids will be superheroes like Ashley. You can do this by signing up to be an organ donor when you get older. I am proud to be an organ donor and hope someday I can save a life, just like how Ashley saved mine.
Wow, amazing.
That's fantastic.
Yeah. Mm. Mm. And one more.
Dr. Callender, while we're waiting for John to bring up, what are the four colleges that you mentioned?
Howard University, Morehouse
Morehouse.
in Atlanta, Georgia,
Mhm.
Meharry Medical College in Nashville, Tennessee, and Charles Drew Medical School in Los Angeles, California.
Okay.
The name of that other battleship is the Missouri.
Yeah, I thought it started with an M. Thank you.
Mhm.
I'm a history buff. I'm writing all this down.
Okay, kids. Do you know that you may be able to save a life? You're going to be so excited about today's lesson plan. Have you heard of organ and tissue donation and transplantation? Miss Johnson, my mom packs tissues in my bag every day. Not these tissues, dear. We're talking about body tissues such as skin, the middle ear, corneas, bone, blood vessels, blood and bone marrow. One time I got burned really bad, had surgery. Grandpa's a nurse and he said I had a tissue transplant. Your grandpa is right. You all can't tell, but I'm a tissue recipient too. My vision used to be very cloudy because of cataracts. Let me show you this. My eye surgeon transplanted a cornea, which is yes, into each eye. Now I can see your pretty faces again. Yay! So now you know how tissues enhance lives. Let's talk about how organs save lives. Well, where do these organs and tissues come from? Great question. They come from living and deceased donors. Deceased meaning they're no longer alive. Now, we must show respect and be grateful for these heroic donors and their families. Can you imagine the number of lives a deceased donor saved? Think about it. Only a deceased donor can give a heart. When a patient's brain stops sending messages to the organs, example, telling the heart to pump blood or the lungs to breathe, organs no longer work to keep that patient alive. After tests confirm there's no brain activity, the organs can be used for transplantation if the person gave prior consent or the family members agree. Yes, it's a sad time for families losing a loved one and for the doctors losing the patient too. But hey, here's the good part. Donation gives families an opportunity to make their loved ones heroes by giving their organs and tissues to those in need. Many families say this final act of kindness always brings them comfort. And all of these organs are transplantable. Miss Johnson, when I was 5 years old, I was sick a lot. The doctors told my parents I was born with a kidney disease. Thank you for being so brave to tell your story, Candace. I bet you can tell us what the kidneys do. Yes, I can. Kidneys remove waste from our bodies when we urinate. You know, pee.
Kidneys do what?
Why can't I do that anymore, Carlos? Well, understanding my body made me look swollen. The awful stuff that they call toxin in my body made my breast smell bad and kids didn't want to play with me. I had to have a treatment called dialysis. It made me angry and I cried a lot because I had no friends. At first, my dad used to hook me up to a machine every night that would clean up my blood while I slept. Class, that's called peritoneal dialysis. After I got several infections, my doctor switched me to hemodialysis. They do that at a dialysis center or hospital, not at home. How does that one work? One needle pulls dirty blood out of the body and passes it through a machine, and another needle puts the clean blood back into the body. I had done it 3 times a week for 3 hours each time. While this was going on, my doctors put me on a transplant waiting list. But waiting can take years, even if you get one. There aren't enough kidneys to go around. Oh, I'm sorry I had to go through that, Candace. Oh, I don't anymore. When my neighbor, Miss Sornigo, found out my parents couldn't give me one of theirs, she became my donor and gave me one of her kidneys. You only need 1 kidney, you know. A kidney from a Native American? She's a different race. My mom says there's only one race, the human race. My family is very grateful for Miss Sornigo for being so kind to us. I'm an organ recipient now. I play sports and everything, and I get awesome grades too. Stop showing off, Candace. I'm sure glad I wasn't born with kidney disease, so I don't have to worry. Candace, you are so mature and smart. I feel like I'm talking to a superstar. We are so proud of you. And to think, we couldn't even tell you've been through all of that. And Mariana, not so fast. Many African Americans suffer from high blood pressure and diabetes, often leading to organ failure later in life. Many of those who are on the transplant waiting list are people who look just like us. Always remember that your parents are helping to protect your kidneys and other organs when they encourage you to eat less salty and starchy foods and drink healthy drinks instead of sugary ones. And if we exercise more, fewer of us will suffer from organ failure and need transplantation. So, children, are we going to make a positive difference?
Yes, Ms. Johnson.
Great job. Now, round of applause for living donor Miss Soaring Eagle for doing such an honorable thing and helping to save Candace's life. And another round of applause for living and deceased donors and their families. Let me show you how adults can indicate their desire to give the gift of life. It's very important for would-be donors to let their family members know their choice.
Why?
Another great question. It makes it easier for family members to honor the wishes of their loved ones. And kids, you know that seatbelts save lives too, so buckle up, okay? This has been a wonderful lesson, jam-packed with information. Let's do a quick recap. Tissue donation does what for recipients?
Improves lives.
And organ donation does what for recipients?
Saves lives.
Now you give yourselves a round of applause. It is important to remember that without people saying yes to donation, there's no transplantation. And if we were in need, we would want someone else to give us the second chance, right?
Yes, Ms. Johnson.
Now here's a catchy tune.
But precious lives I'll say. I don't need organs worth going, share my tissue and gone. Give the gift of life to the suffering and help them to live on. My spirit flies to heaven on sweet April's wing. will be a win-win situation, and I say that wherein is thy slave. Yo, that wherein is thy slave.
I lost it all. I had to start from scratch. Here's what I do to get back.
Okay, any comments or any questions?
That was
about
great.
Fantastic.
Clive, you really did a good job on that. Is transplantation still going on at Howard now?
No, we stopped about 10 years ago, actually.
Dr. Callender, on your presentation, you said there were 40 individuals that were surveyed. Do you have the age range of those 40 individuals?
No, I don't remember anymore. That was in 19. Actually, now that you mention it, it's close to 40 years ago.
And then the other thing I was thinking about, has anybody said like what they're going to look like at their funeral? I'm afraid they may not look like they should be looking like.
Yes, we've had that discussion. And actually, you can have a funeral and you look just like you looked before you died.
Okay.
We can just have a discussion of this and take the slides off. Let's just discuss this for a moment. Okay. Yeah. So so that was a common question that we dealt with, and you can be an organ and tissue donor and still have a normal appearance at your funerals, so that you don't have to worry about, in spite of being an organ tissue donor, looking different at the funeral. So that is, while that is one of the issues that was brought up, that was not an issue that was as common as the other ones.
Okay, and when a person does decide to be an organ, to donate organs, do they know which organs they're going to be donating, or is there, if you sign the card said I want to donate organs?
Generally, you sign for organ donation for any organ that the yes is for any organs that, for all organs. Now, as we mentioned, I think last week, for some tissues, like face and penis and uterus, those require special consent forms. But for just organ donation in general, the yes that you sign when you sign up as a at the motor vehicle and get on the computer, the yes is for any of the organs that, unless you identify a specific organ, then the yes is for any organs that can be used.
So how many organs can a person donate? I mean,
eight organs, 2 lungs, heart, 2 kidneys, pancreas, liver, which can be 1 or 2. Sometimes the liver can be divided into 2. So it's about 8 organs, and of course, there's as many as 80 different tissues that can be used to improve lives. But 8 organs can be used to save lives.
Okay. All right. Thank you.
Any other questions that you may have relative to anything that you saw on the presentation or the videos?
Dr. Callender, one of the men that helped start the program was a cousin, Lewis Stokes.
Oh, Lewis Stokes' cousin?
Yes, cousin.
Yeah,
Family.
Lewis is the one who really, for example, I took my case to Lewis Stokes, and Lewis Stokes then took my case and our case to Lewis Sullivan and John Ruffin. And John Ruffin then took the ball with me and helped us get the $16 million that we got that helped start the effort. But yeah, Lewis Stokes was the key person who started everything.
Great. After you, of course.
Yeah, well, he believed in what I was doing and felt that he thought I was spending all of my money to make this happen. Actually, I never said anything like that. I don't know why he drew that conclusion, but anyway, he therefore decided to try to get monies to support this effort, and lo and behold, it worked because of Lewis Stokes, Lewis Sullivan, and John Ruffin. Any other comments or questions that you have about transplantation or organ tissue donation?
Dr. Callender, because at Howard University, did they stop transplantation due to funding?
Yes. Funding was a major issue.
Is there any way for it to come back or anything like that?
It would take a lot of work to do that and a lot of money. Right now, George Washington and Georgetown are doing the transplants in the city. So it's possible, but it would take a heroic effort to get it started again.
Dr. Callender, during this month of observance, is there like a listing of where various presentations are going to be held to promote or to make the community more aware of the organ transplantation program?
Yeah, there are many presentations, but I don't have a list of them. Yeah.
Well, Dr. Callender, you did a heroic job. There's no question about that. I remember when you would go to different churches and talk about transplantation and organ donation, and you really did a fantastic job.
Thank you. Yeah. Most of my work did begin with the churches. Educating and empowering the churches was the first approach we made, and that was successful because so many people in the churches actually, including the pastors and assistant pastors and church members, had needed organ transplants. So this then was where it began, and then we spread from there to all community groups. But community education and empowerment was the real reason why it became a successful program, because the community is one of the most effective change agents you can have. So if you arm the community by educating and empowering them, then you can make a difference. Difference that was made because the number of African American donors tripled and the number of minority donors doubled as a consequence of our education efforts.
Dr. Callender, and I know you can't go to all the churches, but I'm playing at one of the churches, Bethesda, that they remember you, and they at least once a year remind us about organ transplants. But I'm just thinking the videos that we just had seen, if we're contacted with that, maybe we can get these videos shown during their, especially like in February, Health Month, or etc., to make them aware, because I know there's not enough people to circulate to all these different, particularly churches where they have these myths. And some of the churches still have the myths that they have to be buried whole, intact, with all their organs to go into the pearly gates. I don't know if it's as prevalent as it used to be, because more and more people are being cremated.
Yes, it is still a myth that we have to try to eradicate. And the more opportunities we have to present the message, the more opportunity we have for changing people's mindsets.
Dr. Callender, I certainly, once this program is posted on YouTube, I'm definitely going to forward it to a bunch of people so they can hear about Dr. Ivy and yourself in this whole program. So that's one option. Once the program goes to YouTube, we can send it out to various friends and tell them to watch this YouTube video.
It's on YouTube already.
Okay.
What about schools? Have anybody, we have a lot of teachers on.
Well, we have, yeah, well, those videos are meant to go to middle schools and elementary schools. And we are working with Charles Hart Middle School right now. That's the first school we're working with the hope that we were able to expand this to all of the middle schools in District of Columbia first, and then Maryland and Virginia. That's our goal.
Very good.
And Dr. Callender, I'm sorry, I was thinking about this actual presentation for today when it's posted on YouTube.
Oh, that presentation.
Yeah,
okay.
this presentation for today, I'm going to forward it to everybody I know.
I see.
Dr. Callender, I had a question which we covered before, but I just want to reemphasize the fact that if an individual signs that donor card and passes away and his organs or her organs get donated, maybe like you said, 8 organs might be used to persons otherwise healthy. What happens to the body at that point? Is there, as far as that?
Then the body then goes for the usual funeral process, so that you can have an open casket.
Oh,
and you just like any other person who is funeralized.
Okay, so you have the option for open casket, but you could also do a cremation if you wanted.
Yes, whatever you want. Yeah.
Okay.
I wonder, is the African American population still the highest donor?
No, it isn't. And matter of fact, as of the 2020, I think the deceased donor rate is still good, but the living donor rate has dropped precipitously. And so our real effort for MOTEP for the next 5 years is to increase living donations, because that has dropped off significantly. Because, you know, once you stop getting funds to use to get the message out, then the rates drop back again. So we need to do the same thing we did, but the funds aren't as, we don't have that $16 million we used to have. So makes a difference. Any other comments or questions? Yes, Joyce,
Muted.
you're muted. Can't hear you.
If a person wants to make a donation to your organization, how do they go about doing that?
Okay, National MOTEP, we have a post office box. As a matter of fact, you can actually go to our website, natlmottep.org, and you can make a donation via the website. Or if you actually, I don't have the address for the post office box at the moment, but if you don't want to do it via the website, you can just call 202-865-4888, and we can tell you how you can send a donation directly to a post office box.
Thank
Say
you.
the number again.
202-865-4888. And the website is natlmottep.org.
Thank you.
Any other questions or comments? If not, we have a few months, we can do some of the articles that John has. Thank you very much for your attention and being willing to hear the presentation, as well as watch the videos and give us your comments. This is one of the articles that talk about non-alcoholic fatty liver disease, which of course has been a problem because people, in spite of the term, still think that they have alcoholic liver disease. And actually, non-alcoholic fatty liver disease or steatohepatitis are two different diseases. One is the disease that is reversible, and the non-alcoholic steatohepatitis is not reversible and requires a liver transplant. So if you make a diagnosis of non-alcoholic fatty liver disease, that is treatable by getting your diabetes under control, losing weight, and this is reversible. But the NASH, the non-alcoholic fatty steatohepatitis, is only treatable by a liver transplant. And then there's they wanted to change the name because the stigma that's attached to it. But actually, the name they want to change it to, MASLD, is more confusing. And so the question is, what do you want to do about it? And right now, the recommendation was that it be changed. It hasn't changed yet, but that's the recommendation. Many people have concluded that this is even more ridiculous than the name that they have now. But that's what the specialists recommended. So this is just to let you know that even the experts don't agree on everything. And when they agree, they aren't able to convince everybody else that that's the way to go. So, but the issue is that it is accurate that the terms non-alcoholic fatty liver disease and non-alcoholic steatohepatitis are terms that are equally kind of undesirable. But so what are we going to do about it? I don't know. It's going to be interesting. The change was just recommended over the last month or so. So what's going to happen? I know we had one of our people who actually attended this conference who had such a disease and often was fearful that people would think that she was an alcoholic, when in point of fact, these people are not alcoholics, and the disease is not caused by alcoholism, because alcoholic liver disease causes cirrhosis, and that's what it's called. And so, and why diabetes and insulin resistance causes liver failure, we're not really that positive. But we do know that correcting the diabetes does help. So I just wanted to let you know that even the experts have a lot of difficulty in trying to make things happen in a sensible fashion. I thought this was an interesting article, 10 recommendations to reduce cancer risk. And remember, these are recommendations for cancer prevention. They're not guaranteed to keep you from getting cancer, but they're just ideas. And so avoiding being obesity and being overweight, although there's some data now that suggests that obesity is more of a contributor to cancer than is being overweight. Second, being physically active every day. That's a good idea. And then, of course, cutting down on meats, eating the grains, vegetables, fruits, and beans helps greatly. And then cutting down on fast foods and processed foods, although that is tougher for people who aren't rich. And then, of course, limit your intake of red meat and processed meat. Limit your intake of sugar sweetened drinks, and eliminate or avoid alcohol consumption. And don't rely on supplements to meet your nutritional needs. It means have a healthy diet. And vitamin B12, folic acid, and vitamin D supplements may be appropriate for those who need it. It's interesting, breastfeeding your baby is also desirable. And I think these are just some of the things that you can do to make it less likely for you to have cancer. I don't think that we can say that if you do this, you won't have cancer. But we can say that it will reduce your likelihood to have cancer. Lou, you have a comment or question?
No, I think you've covered it pretty much.
Oh, your hand was raised, so I thought.
No, I'm sorry.
All right, any other comments or questions about the cancer prevention? All right. Now, this is another one about healthy habits, and many of the healthy habits are brought to bear because our average life expectancy has dropped in the United States. And so it becomes more important to remind us of some of the habits that we need to resume. The pandemic has changed a lot for many, and so it's time to get back to what used to be the norm. And so, of course, one of the biggest issues is high blood pressure and insulin resistance. And of course, that diagnosis is made by looking at the hemoglobin A1C. And of course, the lipid profile, knowing what your HDL, which is the good cholesterol, and the LDL, which is the bad cholesterol, what that is, knowing what your C-reactive protein may be helpful. Sometimes a little knowledge is a dangerous thing. Elevations in homocysteine, which are rarely looked at by many, is something that's associated with heart attack, stroke, and Alzheimer's. Then hemoglobin A1C is something that we all should have an idea of what our hemoglobin A1C is. As long as it's under 6, you're in good shape. Vitamin D3 is, knowing what that is important, because if you have vitamin D deficiency, that's important to correct. Many people think that what you eat is as important as anything else, and eating the right foods and avoiding the animal-based foods is thought to be a good idea. Then, of course, there are nutritional supplements, but they are recommended if you are not able to have all of these in your food. Omega-3 fatty acids, all of these things that should be part of the nutritional supplements that you need if you're not having a healthy appetite. If you have a healthy appetite, all these things should be part of your diet. Then you add to that physical exercises, mental exercises, and I think that covers the waterfront. Any other comments about other things that you think are good to increase your lifestyle? This is an article which is really about the same kind of thing. It talks about the 5 places in the world where people live the longest and are the healthiest. Japan, the longest lived women. Italy, the longest lived men. Costa Rica, where they're twice as likely as Americans to reach 90 years of age. Greece, then the Seventh-day Adventist communities as well. And what the Seventh-day Adventists, for the most part, are vegetarians. And the issue is that we should be talking about living instead of dying, that adopting lifestyle habits that allow you to enjoy your day. And these are some of the non-healthy principles they suggest: moving a natural part of your day, knowing your sense of purpose, prioritizing stress relief, like issues like meditation, eating until you're about 80% full, eating a large plant-forward diet, drinking alcohol in moderation, or in fact, eliminating it. It's not a bad idea. Connecting with your community, putting family first, and choosing social circles that support healthy behaviors. I think all these are good to do. And as we age, these are things that we have to keep in mind. And I think everyone should have a sphygmomanometer or blood pressure apparatus at home so they can take their pressure and find out whether they are in the 120 or 80 range or close thereto. These are just some recommendations for living a longer and healthier life. So any comments or thoughts about it, certainly appreciated. This is what the hospital's chief executive office circulated, which I thought was beneficial to us all. Any comment about it?
I noticed that there's never a mention of church or religion, and I'm sure that has the reasoning, but that's a good part of living a good life as well.
Well, the social, I think when they refer to social settings, church is a great social setting. And I think for stress relief, religion is probably, and meditation. Most articles tend to leave that out, as you said, but those are important things that need to be part of the articles. And everything that I write, I try to include meditation. But there's many articles that demonstrate that that people who are religious tend to live longer than people who aren't. This is an interesting article on dementia. One of the things that is problematic about having early warning signs is that other than having your family being there to support you, we aren't really able to do much about slowing down the rate at which dementia affects you. But it is important if you have dementia that your family know about it so they can support you in every way that is possible. Because one person alone can't help the person who has dementia. It's a situation in which a family needs to be involved, and there are actually organizations that will help the family once you have dementia. And these are some of the early short-term memory loss, and as you get older, the memory loss. But most of the memory loss is for what happens recently. People often remember what happened years ago, but they can't remember what happened 5 minutes ago. That's the kind of memory loss that we're talking about. Then difficulty with familiar tasks, things that used to be easy, preparing a meal or driving, filling a place, that becomes difficult. Language problems, vocabulary. Yeah, they mentioned this about our vice president the other day because she substituted some words, and that can be sometimes an early sign or not. And then mood changes, drastic mood changes are suggested. And then, of course, if you become disoriented, then that's a real problem. When you don't know where you are, or get lost a lot, or know what day of the week it is. When you work, you know what day it is. The people who are retired may not have a little more difficulty with that. And then, of course, following a conversation is something that some people may have difficulty with. But that may be a sign as well. Being repetitive is something that is even more suggestive of dementia, particularly keep doing the same thing over and over again. Then you become a loss of initiative, problems with abstract thinking, balance the checkbook, and sometimes these are things that people start doing that lets you know that they're moving towards dementia. Then poor judgment, well, people have poor judgment anyway, sometimes. So, but the fact that the judgment may be even more evident. Choosing to wear a heavy coat on a hot day, like I have done sometimes, maybe thought of as and then withdraw from social activities. It's not a good sign either. And then if you notice personality changes, it's very different from how it used to be. Again, these are signs that may indicate dementia. The real problem about all of this is that neurologists can make the diagnosis, but there's no effective treatment for dementia. And so the real issue is to get family help and help from other sources that will help keep someone who has dementia safe, because they're very harmful to themselves. And so the family needs to be organized to be able to help them from hurting themselves, getting lost, or in other ways, putting themselves in harm's way. Any comment, or any of you have friends who are demonstrating dementia?
Yeah, Dr. Callender, I've been through every one of those stages with my mom. It was something that I had to get help with as a caregiver, and they didn't mention anything about that, but those who recognize these signs and symptoms should, in my opinion, get help for themselves to prepare for that job of supporting someone with that, because for me, the analogy is a slow motion train wreck. The wreck is coming, and there's nothing that we can do about it. Like you said, there's no treatment for it, no medication that's going to fix it. We can slow it down, but it's a train wreck. And at the end, at least with Alzheimer's, and there are many flavors of dementia. Dementia just means losing those mental abilities, but especially with Alzheimer's, at the end, you forget how to eat and how to drink, and how your brain just stops working toward the very end, and very painful to watch. And then you become aware of your own situation as well. Forgetting where your keys are, where your cell phone is. Short term. I mean, these are things that are kind of normal, but they grow in occurrence as you get older. So that's my comment.
And I think your point about the fact that you need to get help as soon as you can, because sometimes if you have a large family, sometimes the family members can help, but one person doing it is not possible. As a matter of fact, you will wind up leaving before the demented person if you don't get help, because there are organizations that will help you and will work with you. They'll come in and take your relative for hours, take them to a safe place and have activities for them, then bring them back later on to allow you some freedom, because otherwise this will exhaust you and actually may even kill you. So
sometimes the support system is totally absent in terms of family members who may be a single child or a single relative that is unable to separate the work or the needs that they need to do for their own family, and to share it with the relative that's older, the mother or father, what have you. because I know I have several patients in the past who have been advised that at least the children have been advised of the needs of the older parent. And you're giving them directions as to how to seek help, and it just doesn't happen. It's unfortunate, but I don't know how to simplify it, how to make it more effective in making younger people understand exactly what the needs of the older person happen to be, and how to get them to be more active in trying to care for them.
I highly recommend Iona Senior Services, which, you know, has a lot of free services, and also in DC, the aging, the branch of the government that deals with aging support is also helpful. But Iona
Is
focus
that spelled I-O-N-A?
Iona Senior Services. It's right in my neighborhood, really, right off of Wisconsin Avenue, near Tenley Circle. It's 2 blocks from the metro, from Tenley Metro. I highly recommend it. They have sessions for the support people, family members, as well as the memory loss individuals can get help from them as well. And much of it's free.
Good to know.
I wanted to share this, that I had a friend, church member, who was a single gentleman. Well, he had one niece in the area, but I realized later on that he must have realized his own self becoming not being able to remember things, and he asked me to get on his bank accounts. And I mean, I just thought, well, he didn't have any family around, so he wanted to put me on his bank accounts. But as it turned out, when he had a fall in his home and it did something with his brain, and he became dependent. And because of the fact that he had put me on his bank accounts, I was able to manipulate getting him help in his home. And when that was no longer accessible, I got him into a assisted living facility. And I even went to the Social Security to stop the taxes coming out so that he could afford to go to a assisted living facility. And I did that for 2.5 years, I think, close to 3 years before he passed. So I guess my comment really is, if you even think that something may be wrong and you don't have anybody that is really close to you, you need to reach out to somebody, or reach out to a family member or whatever, and make them aware and give them some type of authority.
Thank you for sharing. Any other comments? Well, thank you. It's a very important article to help us understand. That is an issue that has become more and more important as we go on, because part of my ethics class, we talk about the need for chaperones, regardless of whether they're the same sex or opposite sex. And those doctors who examine patients without chaperones put themselves in harm's way. because nowadays you're better off if you have a chaperone, whether the patient asks for it or not. Now the question is, do you have the staff that can allow you to do that? And sometimes you don't, but it's something to keep in mind that whenever a patient requests it, you have to have a chaperone. But who should be a chaperone? And I think it's anybody could be a chaperone that's a person who has some medical experience, because we don't have a designated requirement for the person to be a chaperone, but it should be a person who's capable of keeping confidentiality and being able to be a witness to support the fact that there's been no inappropriate behavior. And when you only have you and the other person, that complaint can sexual assault or any other kind of assault can be raised. And so the chaperone should not be one of your friends. It should be somebody who actually is separate from you. And the more credentialed they are, the better. And as they say here, to me, patient that needs to be requested, it should be kind of automatic. And it's essentially 93% of female patients prefer the male, unlikely to really paying attention to it. But especially if you could do a pap smear or anything like that, I think you need to have a medical assistant, chaperone. Any thoughts about this? You have been patients. What are your thoughts about it? Nobody cares?
I'm kind of comfortable with my doctor. As you know, if you keep the same doctor for a long period of time, you get kind of comfortable with them and you don't feel like you need a chaperone. I know some of the specialists that me and my husband go to, they will invite if it's for me, they will invite my husband in the room. If it's for him, they will invite me in the room. But with my primary care physician, I feel quite comfortable. I've been, a patient of hers for years.
Any other comments?
I think it's a comfort level with my doctor's appointments, and especially something in the female area. If it's a male doctor, I had an appointment actually just yesterday, and we talked first, and then for the actual exam, he called the nurse in, and she's used to the practice, and she talked to me beforehand. So I think it gives you an additional comfort level to have that extra person in the room with you. So I agreed to having a chaperone or someone available.
Okay, it doesn't sound like many other people have any comments, so we'll move on, but it's...
I have noticed with some of my doctors of visits that they are offering chaperones, and they have signs posted that we provide chaperones, which is a very comforting thing to know.
Okay. Okay, this is one of the last ones we'll do is we all talk about exercise helping everything, and especially in the brain, and we have more and more articles that are pointing out that exercise improves your mental health. And there are studies which prove it beyond a shadow of a doubt, they say, and there are other studies that aren't so positive. So this is a study that was published in And they said there's little evidence between regular physical exercise and improved cognition in healthy people. And then there are other studies demonstrating the opposite. And so the question is, what do you say to your colleagues and friends and about the importance of exercise? Not about the cardiovascular aspects of it, because they are well recognized, but about the beneficial effects of physical exercise on the brain. And this then is what this article is all about, that there are studies that aren't well structured, that leave some doubt as to whether the cognitive state is improved or affected at all. And so there's still much discussion about it. But I think that the majority of the evidence is that regular exercise is beneficial to the brain.
And doctor, I would think the one thing, you know, well, you brought up cardiovascular, but the aspect of like catching a ball, you know, using your coordination and everything. And then sometimes if you're playing like a small team sport, the actual interaction that you have with other people is very beneficial.
Any other comments? Just good to have an appreciation that there's so many studies around it. Sometimes knowing exactly who they're studying and how long they've been studying it becomes important. You know, the question is, which is more important, physical exercise or social bonding? I think they're both helpful. Now, this is a situation that, and I guess this will be the last one we do, that intense exercise in people who have vascular compromise may be risky. And since we have a vascular surgeon with us today, Doctor, have any comment about this?
Well, I certainly feel that the the increased activity in terms of walking and et cetera, because this is particularly true in the leg, is helpful, but extreme exercise is prohibited, because that way you're calling for a lot more blood flow than you're able to provide, and you run the risk of creating a situation that you really don't want to, gangrene or closure completely of that circulatory system. I'm sure well, that is the area that I'm most involved with, or had been in the past, is people who want to walk and finally they realize that they're having problems with pain in the leg after a certain short distance, and you give suggestions short of surgery that might be helpful, because this is the way it was initially treated 30, 40 years ago, was increased ambulation, to walk and gradually grow collateral circulation. And that is still a conservative way to do that if you have just minimal discomfort. In other words, you can walk a block or two, or a little less maybe. That will do well, particularly in an elderly patient, to just have them continue to walk. And the increase in circulation will be gradual, but it will be positive. So anything that's extreme is sort of the reverse of what you want to accomplish. So I go along with this limitation of how strenuous your physical activity should be in that ischemic situation.
Dr. Ivy, what is stenosis? What does that mean?
Stenosis means the artery is closing. It's getting smaller. So the diameter through which the blood is traveling is decreased. So therefore, the distal organ, or the organ that's being provided with the blood, is not getting the blood that it should. And as a result, the muscles, particularly in the leg, begin to cry out. And that's what we call claudication. The pain stops you from walking. And so that's a result of stenosis and the lack of adequate blood flow to that distal organ.
Thank you.
Mhm.
Okay.
I'm a marathon. Well, used to be a marathon runner,
Mhm.
and I just noticed that it seemed to be that half of the races I ran, you get a report after the race that somebody died, and
Yeah.
usually just cardiac arrest,
Yeah.
and just looked up something that said on the average up to 2 deaths per 100,000 participants in marathons, and so that seems to work out with about the average number of runners in a marathon being about 20,000. And you just had LeBron James' son that had the cardiac arrest, and the football player earlier this year. So yeah,
Shaquille.
intense exercise looks like it can cause cardiac arrest.
Mhm.
Well, I think the cardiac arrest in the marathon probably is the result of the inadequate blood supply to the heart over a period of time. It depends on the physical condition of the person who's running and how accustomed or how well trained are they, plus the age. And unless you go to the extent of getting a coronary arteriogram to see what blood flow is there, you might not know the extent to which you actually have vein artery closure. Now, you may feel fine, but when you go to exert yourself, I mean, a marathon is 26 miles, so that's a pretty long time to get plenty of exertion. So as the progress continues over the first 10 miles or so, this condition may be increasing in terms of inadequate blood flow to the heart. Now, when you talk about cardiac arrest in these young people, like LeBron James' son, that is totally different to the cardiac arrest from the football player. One is trauma, a sudden shock to the heart. That was in football. And with James's son, it's a question of a cardiomyopathy. Either the muscle of the heart is too large, or there's some physical abnormality in the electrical circulation of the heart. So the pattern of regulating the cardiac beat, the beat of the heart, is interfered with because of a circuit problem. That has to be examined. In certain instances, you can help it by putting in an automatic defibrillator. But in certain circumstances, like cardiomyopathy, increased muscle to the heart, then there's nothing you can do about that. You just have to have the patient stop doing that kind of activity because the risk is too great that the next time may be fatal. But James is getting a cardiac workup at the Mayo Clinic to determine which of the two problems he has, because he did not have any injury to the heart. He just had a spontaneous situation. Clive, what do you think?
Yeah, and Shaquille O'Neal's son had the same thing last year, but the difference was he did have an anatomical problem with his heart that had to be corrected.
Mm-hmm.
Yeah.
So,
Thank you so much for that.
Dr. Callender, are there exercises, particularly for the heart muscle?
You talking to, you speak to me? Well, you mean for what situation?
For situations where your heart muscle needs to be strengthened.
Well, there's when we certain circumstances create a problem where the muscle of the heart thins out, like in in congestive heart failure. If the left ventricle is distended, the muscle is not too thick. As a matter of fact, it's thin. The chamber is larger than it ought to be. So the muscle is weaker. There's no way you can strengthen that muscle. You can add a pump system to augment or help that, but otherwise there's no medication, no exercise, or anything like that that can strengthen the muscle. On the other hand, if you have a hypertrophy of the muscle, that means a very thick chamber, thick wall, the chamber is reduced, so the blood supply again is reduced in terms of the coronary blood flow and the output of the heart because of the extensive muscle of the heart. So you can't go in and decrease the muscle by surgery. There's very little that you can actually do other than reduce the degree to which you submit to exercise.
There's a hand raised. Is there a question?
Yes, I have a question. This is Elizabeth. Can you hear me?
Yes.
Yes.
Oh, yes, I have a question. My concern is about when you see people that have the swelling of the ankle and sometimes swelling of the leg. Is that related to the heart and lungs as well?
Well, that can be. In congestive heart failure, that means that the heart is not putting out enough blood through the arteries. The left ventricular output is reduced. And that means that blood backs up in the venous system because the blood has to return to the heart. But if you can't pump the blood down to the distal end of the extremity, then you certainly can't pump it back up. So as a result, the veins distend in the leg and swelling is there. If you have the patient lie down, elevate the legs, you notice that the swelling will go down. But the patient is in a recumbent position with what we call Trendelenburg, so that the feet are up, elevated, pushing the venous blood back to the heart. The swelling will go down. But when they get up again and try to move about, the same problem exists. Also, the fluid backs up in the lungs. And this is the shortness of breath that comes with congestive heart failure. The output, the cardiac output is decreased. So the blood leaving the heart, the left ventricle is inadequate to supply the body blood, the needs of the body, and it slows down. And when it slows down, that means all systems back up. And the venous blood returning to the heart can't get back. It's stuck in the tissues, either in the lungs or in the legs, and you have congestive failure.
Thank you very much for a good answer. And we've had an interesting session today, complexity of issues, and we're so thrilled to welcome Dr. Lewis Ivy back. And thank you all for joining us today, and see you next week.
Yes. Thank you.
See you next week, guys. Take care.
All right. See you, everybody.
Have a good week.
Okay, goodbye.
Bye.